Chapter 3 of Moore for anatomy, upper limb. Okay, overview of upper limb. The upper limb is characterized by its mobility and ability to grasp, strike, and conduct fine motor skills or manipulation. These characteristics are especially marked in the hand when performing manual activities such as buttoning a shirt. Synchronized interplay occurs between the joints of the upper limb to coordinate the intervening segments to perform smooth, efficient motion at the most workable distance or position required for a specific task. Efficiency of hand function results in large part from the ability to place it in the proper position by movements at the scapulothoracic, glenohumeral, elbow, radioulnar, and wrist joints. The upper limb consists of four major segments, which are further subdivided into regions for precise description. First region is the shoulder, which is the proximal segment of the limb that overlaps the part of the trunk, thorax, and the back, and lower lateral neck. It includes the pectoral, scapular, and deltoid regions of the upper limb, and the lateral part, or the greater supraclavicular fossa of the lateral cervical region. It overlies half of the pectoral girdle. The pectoral girdle or the shoulder girdle is a bony ring, incomplete posteriorly, formed by the scapulae and clavicles, and completed anteriorly by the manubrium of the sternum or part of the axial skeleton. Second region is the arm, which is the first segment of the free upper limb, or the mobile part of the upper limb independent of the trunk, and the longest segment of the limb. It extends between and connects the shoulder to the elbow and consists of anterior and posterior regions of the arm, centered around the humerus. Third is the forearm, which is the second longest segment of the limb, and it extends between and connects the elbow and the wrist, and it includes anterior and posterior regions of the forearm overlying the radius and the ulna. Last region is the hand, which is the part of the upper limb distal to the forearm that is formed around the carpus, metacarpus, and phalanges. It is composed of the wrist, palm, dorsum of the hands, and digits or fingers, including the opposable thumb, and it is richly supplied with sensory nerve endings for touch, pain, and temperature. Comparison of upper and lower limbs. Developing in similar fashion, the upper and lower limbs share many common features. However, they are sufficiently distinct in structure to enable markedly different functions and abilities. Because the upper limb is not usually involved in weight bearing or motility, its stability has been sacrificed to gain mobility. The upper limb still possesses remarkable strength, and because of the hand's ability to conform to a paddle or assume a gripping or platform configuration, it may assume a role in motility in certain circumstances. Both the upper and lower limbs are connected to the axial skeleton, your cranium, vertebral column, and associated thoracic cage, via the bony pectoral and pelvic girdles, respectively. The pelvic girdle consists of the two hip bones connected to the sacrum. The pectoral girdle consists of the scapulae and clavicles connected to the manubrium of the sternum. Both girdles possesses a large flat bone located posteriorly, which provides for attachment of proximal muscles and which connects with its contralateral partner anteriorly via bony braces. The pubic rami and clavicles, however, the flat iliac bone, small bony braces, the pubic rami, and clavicles. However, the flat iliac bones of the pelvic girdle are also connected posteriorly through their primary attachment to the sacrum via the essential rigid, weight-transferring sacroiliac joints. This posterior connection to the axial skeleton places the lower limb inferior to the trunk, enabling them to be supportive as they function primarily in relation to the line of gravity. Furthermore, because the two sides are connected both anteriorly and posteriorly, the pelvic girdle forms a complete rigid ring that limits mobility, making the movements of one limb markedly affect the movements of the other. The pectoral girdle, however, is connected to the trunk only anteriorly via the sternum. By flexible joints with 3 degrees of freedom, it is an incomplete ring because the scapulae are not connected with each other posteriorly. Thus, the motion of the upper limb is independent of the other, and the limbs are able to operate effectively anteriorly to the body at a distance and level that enable precise eye-hand coordination. In both the upper and lower limbs, the long bone of the most proximal segment is the largest and is unpaired. The long bones increase progressively in number but decrease in size and in the more distal segments of the limb. The second most proximal segments in both limbs, that is the leg and the forearm, has two parallel bones. Although only in the forearm do both articulate with the bone of the proximal segment, and only in the leg do both articulate directly to the distal segment. Although the paired bones of both the leg and forearm flex and extend as a unit, only those of the upper limb are able to move, supinate and pronate relatively to each other. The bones of the leg are fixed in the pronated position. The wrist and ankle have a similar number of short bones, 8 and 7 respectively. Both groups of short bones interrupt a series of long bones that resumes distally with several sets of long bones of similar length, with a similar number of joints of essentially the same type. The digits of the upper limb, fingers including thumb, are the most mobile parts of either limb. However, all other parts of the upper limb are more mobile than are the comparable parts of the lower limb. Okay, bones of the upper limb. The pectoral girdle and bones of the free part of the upper limb form the superior appendicular skeleton. These are the pelvic girdle and bones of the free part of the lower limb form the inferior appendicular and the pelvic girdle and the bones of the free part of the lower limb form the inferior appendicular skeleton. The superior appendicular skeleton articulates with the axial skeleton only at the sternoclavicular joint, allowing great mobility. The clavicles and scapulae of the pectoral girdle are supported, stabilized, and moved by axial appendicular muscles that attach to the relatively fixed sternum and vertebrae of the axial skeleton. Clavicle. The clavicle or collarbone connects the upper limb to the trunk. The shaft of the clavicle has a double curve in a horizontal plane. Its medial half is convex anteriorly and its sternal end is enlarged at the triangular where it articulates with the manubrium of the sternum at the sternoclavicular SC joint. Its lateral half is concave anteriorly and its acromial end is flat where it articulates with the acromion of the scapulae at the acromioclavicular or AC joint. The medial two digits of the shaft of the clavicle are convex anteriorly, whereas the lateral third is flattened and concave anteriorly. This curvature increases the resilience of the clavicle and gives it the appearance of an elongated capital S. The clavicle serves as movable, crane-like strut for rigid support from which the scapula and free limb are suspended, keeping them away from the trunk so that the limb has maximum freedom in motion. The strut is movable and allows the scapula to move on the thoracic wall at the scapulothoracic joint, increasing the range of motion of the limb. Fixing the strut in position, especially after its elevation, enables elevation of the ribs for deep inspiration. And also, the clavicle forms one of the bony boundaries of the cervicoaxillary canal, which is the passageway between the neck and arm, affording protection to the important neurovascular bundle supplying the upper limb. Clavicle also transmits shock or traumatic impacts from the upper limb to the axial skeleton. The clavicle is a subcutaneous and palpable throughout its length and is often used as a landmark for clinical procedures. Although it is designated as a long bone, the clavicle has no medullary or marrow cavity. It consists of spongy or trabecular bone with a shell of a compact bone. The superior surface of the clavicle, lying just deep in the skin and platysma muscle, is a subcutaneous tissue. In the subcutaneous tissue is smooth. The inferior surface of the clavicle is rough because strong ligaments bind to it, and the first rib near its external end and suspend the scapula from its acromial end. The conoid tubercle near the acromial end of the clavicle gives attachment to the conoid ligament, the medial part of the coracoclavicular ligament by which the remainder of the upper limb is passively suspended by the clavicle. Also near the acromial end, the clavicle is trapezoidal line. trapezoid line, to which the trapezoid ligament attaches. It is the lateral part of the coracoclavicular ligament. The subclavian groove or the groove for the subclavius, in the medial third of the shaft of the clavicle, is the site of attachment of the subclavius muscle. More medially is the impression for the costoclavicular ligament, a rough, often depressed oval area that gives attachment to the ligament binding the first rib to the clavicle, limiting elevation of the shoulder. Scapula. Scapula or shoulder blade is a triangular flat bone that lies on the posterolateral aspect of the thorax, overlying the second to seventh ribs. The convex posterior surface of the scapula is unevenly divided by a thick projecting ridge of bone. The spine of the scapula into a small supraspinous fossa and a much larger infraspinous fossa. The concave costal surface of most of the scapula forms a large subscapular fossa. The broad bony surfaces of the three fossae provide attachment for fleshy muscles. The triangular body of the scapula is thin and translucent superior and inferior to the spine of the scapula, although its borders, especially the lateral one, are somewhat thicker. The spine continues laterally as the flat, expanded acromion, which forms the subcutaneous point of the joint and articulates with the acromial end of the clavicle. The deltoid tubercle of the scapular spine is the prominence indicating the medial joint of attachment of the deltoid. The spine and acromion serve as levers for the attached muscles, particularly the trapezius. Because the acromion is a lateral extension of the scapula, the AC joint is placed lateral to the mass of the scapula and its attached muscles. The glenohumeral or shoulder joint on which these muscles operate is almost directly inferior to the AC joint. Thus, the scapular mass is balanced with that of the free limb. And the suspending structure coracoclavicular ligament lies between the two masses. Superolaterally, the lateral surface of the scapula has a glenoid cavity, which receives and articulates with the head of the humerus at the glenohumeral joint. The glenoid activity is a shallow concave oval fossa directed anterolaterally and slightly superiorly, that is considerably smaller than the ball or the head of the humerus, for which it serves as a socket. The beak-like coracoid process is superior to the glenoid cavity and projects anterolaterally. This process also resembles in size, shape, and direction a bent finger pointing to the shoulder, the knuckle of which provides the inferior attachment for the passively supporting coracoclavicular ligament. The scapula has medial, lateral, and superior borders, and superior, lateral, and inferior angles. When the scapular body is in the anatomical position, the thin medial border of the scapula runs parallel to and approximately 5 cm lateral to the spinous processes of the thoracic vertebrae. Hence, it is often called the vertebral border. From the inferior angle, the lateral border of the scapula runs superolaterally toward the apex of the axilla. Hence, it is often called the axillary border. The lateral border is composed of a thick bar of bone that prevents buckling of these stress-bearing regions of the scapula. The lateral border terminates in the truncated lateral angle of the scapula, the thickest part of the bone that bears the broadened head of the scapula. The glenoid cavity is the primary feature of the head. The shallow constriction between the head and body defines the neck of the scapula. The superior border of the scapula is marked near the junction of its medial 2/3 and lateral third by suprascapular notch, which is located where the superior border joins the base of the coracoid process. The superior border is the thinnest and shortest of the three borders. The scapula is capable of considerable movement on the thoracic wall at the physiological scapulothoracic joint, providing the base from which the upper limb operates. These movements enabling the arm to move freely are discussed later in this chapter with the muscles that move the scapula. Humerus. The humerus or the arm bone is the largest bone of the upper limb. It articulates with the scapula and the glenohumeral joint, and the radius and the ulna at the elbow joint. The proximal end of the humerus has a head, surgical and anatomical necks, and the greater and lesser tubercles. The spherical head of the humerus articulates with the glenoid cavity of the scapula. The anatomical neck of the humerus is formed by the groove circumscribing the head and separating it from the greater and lesser tubercles. It indicates the line of attachment from the glenohumeral joint capsule. The surgical neck of the humerus, a common site of fracture, is the narrow part distal to the head and tubercles. The junction of the head and neck with the shaft of the humerus is indicated by the greater and lesser tubercles, which provide attachment and leverage to some scapulohumeral muscles. The greater tubercle is at the lateral margin of the humerus, where the lesser tubercle projects anteriorly from the bone. The intertubercular sulcus or bicipital groove separates the tubercles and provides protective passage for the slender tendon of the long head and the biceps muscle. The shaft of the humerus has two prominent features. First, the dental tuberosity, laterally for attachment of the dental muscle, and the oblique radial groove or groove for the radial nerve or spiral groove posteriorly. The radial nerve and profunda brachii artery lie in the groove as they pass anterior to the long head and between the medial and lateral heads of the tricep brachii muscle. The inferior end of the humeral shaft widens at the sharp medial and lateral supraepicondylar or supracondylar ridges form, and distally in the especially prominent medial epicondyle and lateral epicondyle, providing for muscle attachment. The distal end of the humerus, including the trochlea, capitulum, olecranon, coronoid, and radial fossae, makes up the condyle of the humerus. The condyle has two articular surfaces, a lateral capitulum for articulation with the head of the radius and medial spool-shaped and pulley-like trochlea for articulation of with proximal end, or the trochlear notch of the ulna. Two fossae or hollows occur back to back superior to the trochlea, making the condyle quite thin between the epicondyles. Anteriorly, the coronoid fossa receives the coronoid process of the ulna during full flexion of the bone. Posteriorly, the olecranon fossa accommodates the olecranon of the ulna during full extension of the elbow. Superior to the capitulum anteriorly, a shallow radial fossa accommodates the edge of the head of the radius when the forearm is fully flexed. Okay, bones of the forearms. The two forearm bones serve together to form the second unit of articulated mobile strut, the first unit being the humerus, with a mobile base formed by the shoulder that positions the hand. However, because this unit is formed by two parallel bones, one of which, the radius, can pivot about the other, the ulna, supination and pronation are possible. This makes it possible to rotate the hand when the elbow is flexed. The ulna. The ulna is the stabilizing bone of the forearm and is the medial and longer of the two forearm bones. Its more massive proximal end is specialized for articulation with the humerus proximal at the head of the radius laterally. For articulation with the humerus, the ulna has two prominent projections. First, the olecranon, which projects proximally from its posterior aspect, forming the point of the elbow, and serves as a short lever for extension of the elbow, and second, the coronoid process, which projects anteriorly. The olecranon and coronoid processes forms the wall of the trochlear notch, which in profile resembles the jaws of a crescent wrench as it grips or articulates with the trochlea of the humerus. The articulation between the ulna and humerus primarily allows only flexion and extension of the elbow joint, although a small amount of abduction and adduction occurs during pronation and supination of the forearm. Inferior to the coronoid process is the tuberosity of the ulna for attachment of the tendon of the brachialis muscle. On the lateral side of the coronoid process is a smooth, rounded concavity concavity, the radial notch, which receives the broad periphery of the head of the radius. Inferior to the radial notch on the lateral surface of the ulnar shaft is a prominent ridge, the supinator crest. Between it and the distal part of the coronoid process is a concavity, the supinator fossa. The deep part of the supinator muscle attaches to the supinator crest and fossa. The shaft of the ulna is a thick and cylindrical proximally, but it tapers, diminishing in diameter as it continues distally. At the narrow distal end of the ulna is a small but abrupt enlargement, the disc-like head of the ulna, with a small, conical ulnar styloid process. The ulna does not reach and therefore does not participate in the wrist or radiocarpal joint. The radius. Radius is the lateral and shorter of the two forearm bones. Its proximal end includes a short head, neck, and medially directed tuberosity. Proximally, the smooth superior aspect of the discoid head of the radius is concave for articulation with the capitulum of the humerus during flexion and extension of the elbow joint. The head of the radius also articulates peripherally with the radial notch of the ulna. Thus, the head is covered with articular cartilage. The neck of the radius is a constriction distal to the head. The oval radial tuberosity is distal to the medial part of the neck and demarcates the proximal end, head and neck, of the radius from the shaft. The shaft of the radius, in contrast to that of the ulna, gradually enlarges as it passes distally. The distal end of the radius is essentially four-sided when sectioned transversely. Its medial aspect forms a concavity, the ulnar notch, which accommodates the head of the ulna. Its lateral aspect becomes increasingly ridge-like, terminating distally in the styloid process of the radius. Projecting posteriorly, the dorsal tubercle of the radius lies between otherwise shallow grooves for the passage of the tendons of forearm muscles. The styloid process of the radius is larger than the ulnar styloid process and extends farther distally. This relationship is of clinical importance when the ulna or the radius is fractured. Most of the length of the shafts of the radius and ulna is essentially triangular in cross-section, with a rounded superficial directed base and an acute deeply directed apex. The apex is formed by a section of the sharp interosseous border of the radius or ulna that connects to the thin, fibrous interosseous membrane of the forearm. The majority of fibers of the interosseous membrane run an oblique course, passing inferiorly from the radius as they extend medially to the ulna. Thus, they are positioned to transmit forces received by the radius via the hands to the ulna for transmission to the humerus. Bones of the hand. The carpus or wrist is composed of 8 carpal bones arranged in proximal or distal rows of 4, located at the junction of a forearm and hand. These small bones gives flexibility to the carpus. The carpus is markedly convex from one side to side posteriorly and concave anteriorly, augmenting movement at the wrist joint. The 2 rows of carpal bones glide in each other. In addition, each bone glides on those adjacent to it. The word wrist is often used incorrectly. It should not be used as synonym for the carpus because it is correctly applied to the distal end of the forearm which around which a wristwatch or bracelets are worn. Okay, from the lateral to medial, the 4 carpal bones in the proximal row are as follows. First is the scaphoid bones, a boot-shaped bone that articulates proximally with the radius. It has a prominent scaphoid tubercle and is the largest bone in the proximal row of a carpus. Second is lunate, which is a moon-shaped bone between the scaphoid and triquetral bones. It articulates proximally with the radius and is broader anteriorly than posteriorly. Third is the triquetrum, which is a pyramidal bone on the middle side of the carpus. It articulates proximally with the articular disc of the distal radio-ulnar joint. Last is the pisiform, which is a small P-shaped bone that lies on the palmar surface of the triquetrum. From the lateral to medial, the 4 carpal bones in distal row are as follows. First, you have your trapezium, which is a 4 sided bone on the lateral side of the carpus. It articulates with the first and second metacarpal, scaphoid, and trapezoid bones. Second is the trapezoid bone, which is a wedge-shaped bone that resembles the trapezium. It articulates with the second metacarpal, trapezium, capitate, and scaphoid bones. For capitate, third is capitate, which is a head-shaped bone with a rounded extremity. Extremity is the largest bone in the corpus. It articulates primarily with the third metacarpal, distally, and with the trapezoid, scaphoid, lunate, and hamate. Last is hamate, which is a wedge-shaped bone on the medial side of the hand. It articulates with the fourth and fifth metacarpal, capitate, and triquetral bones. It has a distinctive hook process, the hook of hamate, that extends anteriorly. The proximal surface of the distal row of the carpal bones articulate with the proximal row of the carpal bones, and their distal surfaces articulate with the metacarpus. The metacarpus form the skeleton of the palm of the hand between the carpus and phalanges. It is composed of 5 metacarpal bones or metacarpals. Each metacarpal consists of a base, shaft, and head. The proximal bases of the metacarpal articulates with the carpal bones. The distal heads of metacarpal articulates with the proximal phalanges and forms the knuckles of the hands. The first metacarpal of the thumb is the thickest and the shortest of these bones. The third metacarpal is distinguished by a styloid process on the lateral side of its bases. Each digit or finger has 3 phalanges except for the first, or the thumb, which has only 2. However, the phalanges of the first digit are stouter than those in the other finger. Each phalanx has a base proximally, a shaft or a body, and a head distally. The proximal phalanges are the largest, the middle ones are the intermediate size, and the distal ones are the smallest. The shafts of the phalanges are tapered distally. The terminal phalanges are flattened and expanded at their distal ends, which underlie the nail beds. Ossification of bones of hands. Radiographs of the wrist and hand are commonly used to assess skeletal age. For clinical studies, the radiographs are compared with a series of standards in Radiographics Atlas of the skeletal development to determine skeletal age. Ossification centers are usually obvious during the first year. However, they may appear before birth. Each carpal bone usually ossifies from one center postnatally. The centers for the capitate and hamate appear first. The shaft of each metacarpal begins to ossify during fetal life. Ossification centers appear postnatally in the heads of the 4 medial metacarpals and in the base of the first metacarpal. By age 11, ossification centers of all carpal bones are visible. Surface anatomy of the upper limb bones. Most bones of the upper limb offer a palpable segment of the surface, or noticeable exceptions being the lunate and trapezoid, enabling the skilled examiner to discern abnormalities owing to trauma or fracture or dislocation or malformation. The clavicle is subcutaneous and can be easily palpated throughout its length. Its sternal end projects superior to the manubrium of the sternum. Between the elevated sternal ends of the clavicle is the jugular notch. The acromial end of the clavicle often rises higher than the acromion, forming a palpable elevation at the acromioclavicular or AC joint. The acromial end can be palpated 2 to 3 cm medial to the lateral border of the acromion, particularly when the arm is alternately flexed and extended. Either or both ends of the clavicle may be prominent. When present, this condition is usually bilateral. Note the elasticity of the skin over the clavicle and how easily it can be pinched into a mobile fold. This property of the skin is useful when ligating or tying a knot around the third part of the subclavian artery. The skin lying superior to the clavicle is pulled down onto the clavicle and then incised. After the incision is made, the skin is allowed to return to its position superior to the clavicle, where it overlies the artery. Thus, it is not endangered during the incision. As the clavicle passes laterally, its medial part can be felt to be convex anteriorly. The large vessels and nerves of the upper limb pass posterior to this convexity. The flattened acromial end of the clavicle does not reach the point of the shoulder. formed by the lateral tip of the acromion of the scapula. The acromion of the scapula is easily felt and is often visible, especially when the deltoid contrasts against resistance. The superior surface of the acromion is subcutaneous and may be traced medially to the AC joint. The lateral posterior border of the acromion meet to form the acromial angle. The humerus in the glenoid cavity and deltoid muscle form the rounded curve of the shoulder. The crest of the scapular spine is subcutaneous throughout and easily palpated. When the upper limb is in the anatomical position, the superior angle of the scapula lies at the level of the T2 vertebra. Medial end of the scapular spine is opposite the spinous process of the T3 vertebra. Inferior angle of the scapula lies at the level of the T7 vertebra near the inferior border of the 7th rib and 7th intercostal space. The medial border of the scapula is palpable inferior to the root of the spine of the scapula as it crosses the 3rd to 7th ribs. The lateral border of the scapula is not easily palpated because it is covered by the teres major and minor muscles. When the upper limb is abducted and the hand is placed at the back of the hand, the scapula is rotated elevating the glenoid acclivity such that the medial border of the scapula parallels the 6th rib. Thus, it can be used to estimate its position and deep to the rib the oblique fissure of the lung. The inferior angle of the scapula is easily felt and is often visible. It is grasped when testing movements of the glenohumeral joint to immobilize the scapula. The coracoid process of the scapula can be felt by palpating deeply at the lateral side of the clavipectoral or deltopectoral triangle. The head of the humerus is surrounded by muscles except inferiorly. Consequently, it can be palpated by pushing the fingers well up in the axillary fossa or the armpit. The arm should not be fully abducted, otherwise the fascia in the axilla will be tense and impede palpation of the humeral head. When the arm is moved, the scapula is fixed or held in place. The head of the humerus can be palpated. The greater tubercle of the humerus may be felt within the person's arm by the side on the palpation through the deltoid inferior to the lateral border of the acromion. In this position, the greater tubercle is the most lateral bony point of the shoulder and, along with the deltoid, gives the shoulder its rounded contour. When the arm is abducted, the greater tubercle is pulled beneath the acromion and is no longer palpable. The lesser tubercle of the humerus may be felt with difficulty by deep palpations through the deltoid on the anterior aspect of the arm, approximately 1 cm laterally and slightly inferior to the tip of the coracoid process. Rotation of the arm facilitates palpations of this tubercle. The location of the intertubercular sulcus or bicipital groove between the greater and the lesser tubercles is identifiable during flexion and extension of the elbow joint by palpating in an upward direction along the tendon of the long head of the biceps brachii as it moves through the intertubercular groove. The shaft of the humerus may be felt in varying distinctness through the muscles surrounding it. No part of the proximal part of the humerus shaft is subcutaneous. The medial and lateral epicondyles of the humerus are subcutaneous and easily palpated on the medial and lateral aspects of the elbow region. The knob-like medial epicondyle projecting posteromedially is more prominent than the lateral epicondyle. When the elbow is partially flexed, the lateral epicondyle is visible. When the elbow is fully extended, the lateral epicondyle can be palpated but not seen deep to a depression on the posterolateral aspect of the elbow. The olecranon of the ulna can be easily palpated. When the elbow joint is extended, observe that the tip of the olecranon and the humeral epicondyles lie in a straight line. This is when the elbow is flexed, the olecranon descends until its tip forms the apex of an approximately equilateral triangle, of which the epicondyles form at the angle at the base. These normal relationships are important in diagnosis of certain elbow injuries, like dislocation of the elbow joint. The posterior border of the ulna, palpable throughout the length of the forearm, demarcates the posteromedial boundary between the flexor pronator and the extensor supinator compartments of the forearm. The head of the ulna forms a large, rounded subcutaneous prominence that can be easily seen and palpated on the medial side of the dorsal aspect of the wrist, especially when the hand is pronated. The pointed subcutaneous ulnar styloid process may be felt slightly distal to the rounded ulnar head when the hand is supinated. The head of the radius can be palpated and felt to rotate in the depression on the posterolateral aspect of the extended elbow joint, just distal to the lateral epicondyle of the humerus. The radial head can also be palpated as it rotates during pronation and supination of the forearm. The ulnar nerve feels like a thick cord where it passes posterior to the medial epicondyle of the humerus. Pressing the nerve here evokes an unpleasant funny bone sensation. The radial styloid process can be easily palpated in the anatomical snuff box on the lateral side of the wrist. It is larger and approximately 1 centimeter more distal than the ulnar styloid process. The radial styloid process is the easiest to palpate when the thumb is abducted. It is overlaid by the tendons of the thumb muscles because the process extends more distally than the ulnar styloid process. More ulnar deviation than radial deviation of the wrist is possible. The relationship of the radial and ulnar styloid processes is important in the diagnosis of certain wrist injuries. Proximal to the radial styloid process, the anterior, lateral, and posterior surfaces of the radius are palpable for several centimeters. The dorsal tubercle of radius is easily felt around the middle of the dorsal aspect of the distal end of the radius. The dorsal tubercle acts as a pulley for the long extensor tendon of the thumb, which passes medial to it. The pisiform can be felt on the anterior aspect of the medial border of the wrist and can be moved from side to side when the hand is relaxed. The hook of the hamate can be palpated in the deep pressure of the medial side of the palm, approximately 2 centimeter distal and lateral to the pisiform. The tubercles of the scaphoid and trapezium can be palpated at the base of the medial aspect of the thenar eminence, or the ball of thumb, when the hand is extended. The metacarpals, although overlain by strong extensor tendons of the digits, can be palpated on the dorsum of the hand. The heads of the bones form the knuckles of the first. The third metacarpal is the most prominent. The styloid process of the third metacarpal can be palpated approximately 3.5 cm from the dorsal tubercle of the radius. The dorsal aspect of the phalanges can also be easily palpated. The knuckles of the fingers are formed by the heads of the proximal and middle phalanges. When measuring the upper limb or segments of it for comparison with the contralateral limb or with standards for normal limb growth or size, the acromial angle, lateral epicondyle of the humerus, styloid process of the radius, and the tip of the third digit are most commonly used as measuring points, with the limb relaxed or dangling, but with palms directed anteriorly. Because the disabling effects of an injury to an upper limb, particularly the hand, are far out of proportion to the extent of the injury, a sound understanding of the structure and function of the upper limb is of the highest importance. Knowledge of its structure without understanding of its function is almost useless clinically because the aim of treating an injured upper limb is to preserve or restore its function.